Are
Yes,
we
ma'am.
okay? Anand, you can see
Yes,
me?
ma'am. It is
Okay.
visible, ma'am. It is fine now.
Okay. So I'd like to introduce myself. I'm a pediatric endocrinologist working in the endocrinology department. And there are not pediatricians in every department among the faculty and residents. And therefore, usually this lecture is placed in the 01 panel. Mainly just to give a little glimmer about physiology and pathophysiology and investigations in children, and then to just tell you who are the resource people and resource items which are there in SGPGI for those people who are working in departments where there is no pediatrician. So I always begin, people must be bored who have seen this slide before, but most of you are new. Always begin by asking whether you all would be able to understand why I use this to exemplify children are not little adults. But since this is not in the interactive mini auditorium, so I will only have to pose the question and give the answer. This depiction of baby Jesus in the picture on the right hand side by Raphael really shows how we picture a baby. Whereas a similar picture of baby Jesus with Mother Mary, made a couple of centuries earlier, does not really look like a baby. And what do we see is the difference? We just say it by intuition, but when we see in great detail, we can make out that in this baby the head is much bigger, whereas here the head assumes the proportion of a man. So this looks like a little man, whereas this looks actually like a baby. The trunk is long and the limbs are smaller. The cheeks are a little chubby, so the expression on the face is different. Um, and many other things are also exist, but these are some things which immediately tell us that, oh, this something is not quite right how we view a baby in the picture on the left hand side. And so I want all of you to remember this, to think that children are not just little adults. There are lots of differences in their morphology, physiology, investigations, etc., which dictate for differences in how we approach them for treatment. So let us come to some aspects about physiology. Here we can see the on the y-axis is the oxygen demand of the body in minute ventilation per kg body weight per day. And we can see how much more, 3 times more is the minute ventilation in an infant as compared to the future adult. Similarly, uh, is the calorie needs and the water needs. The calorie needs per kg per day and the water needs in ml per kg per day are 2 to 3 times that which an adult would need. And the relationship between surface area and body mass, the surface area to body mass ratio or the surface area to volume ratio is about 3 times higher in an infant and 2 times higher in a toddler as compared to adults. And this has a bearing upon temperature loss. We know that the greater the relative surface area, the greater the temperature loss, water loss, and therefore the more difficulty in temperature control and many other things. Coming from physiology, going on to history taking. Um, as many of the adult colleagues always laugh at us pediatricians and say, "आप लोगों को क्या तकलीफ है? You pediatricians really hardly have to spend 5 minutes on history, because we have to spend 40-45 minutes for taking a 40-year or 50-year history from the patient." And indeed, Hutchison, our famous Hutchison, he says, with what are called subjective symptoms in children, that is history taking, you are not in any way troubled because there are none. However, though the advantage is that history is brief, one problem is there, that the parents' version of the history may actually reflect denial. And secondly, comes a different way of history, and that is observation. History taking is replaced by observation in pediatrics. And one of the famous pediatricians said, previous to speech, God has given to child a language which philosophers call natural language. It is the language of signs. And the famous founder of the Great Ormond Street Hospital for Children said, for though the infant cannot talk, It has a language of its own, and this language, it must be your first object to learn. So these people are emphasizing that observation takes the place of history taking in pediatrics. If you have not cultivated your faculties of observation, you cannot learn it because it is a language of signs. Coming from history taking to examination, I quote Thomas Roch, the proper method of learning to understand sick infants and children is to first notice their peculiarities in health. And in childhood, we have something which we don't have in adulthood, that is growth, puberty, development. Let us come to growth charts. The blue growth charts represent boys and the pink represent girls. They are used in many of the departments of our hospital. Um, these, uh, these show how nationally representative, well-nourished boys or girls grow from the age of 1 to 2 years till the age of 18 years in weight and in height. And some of the growth charts also have the BMI on the backside. How do we use these charts? When we take a height and a weight, we must plot it. And plotting on a growth chart helps us to place the height or the weight against the perspective of a national reference. So, for example, we took this height, we feel it is small, but when we place it on the growth chart, we understand that it is still within the normal limits on the fifth centile of the national standards for girls. But it also places the height against the perspective of the mid-parental height. So if we plot the average of mother's and father's height adjusted towards a girl and plot it on the same growth chart on the adult vertical, that is the 18-year vertical, we are shocked to find that this family has a very tall set of parents. For them, this girl who is on the fifth centile, though within the national centile is normal, but still she is short for mid-parental height. It gives us a big alert. Is there something going on? Why isn't she as tall as her parents? And thirdly, the height record over the several years, if taken by a pediatrician or physician or family doctor, helps us to detect deceleration. So this family doctor for this girl had been diligently taking the heights. She had been following the height centile of her parents, but lo and behold, somewhere in the mid childhood or later childhood, she started decelerating. Instead of 95th centile, she reached the 50th centile. After some time, she reached the 5th centile. And if we did not intervene after seeing this trend, she would actually have become way below the 5th centile and actually deteriorated in terms of whatever disease underlying she had. Coming from growth, we come to physical examination for puberty. Now, we must know the normal time of start of puberty. Suppose we should know that the earliest puberty starts in a girl is 8 years, and the latest it can normally start in a girl is 13 years. And similarly, in a boy, 9 years and 14 years. Why should we know this? If we see a boy who is 13 years old and has no pubic hair, testicular enlargement, we may send him on to a huge series of investigations thinking he has delayed puberty. We may look at his pituitary, we may get an MRI done, all sorts of things. But if we knew that he still has one more year in the normal course of events to show the start of puberty, we may very well counsel the parents and tell them to hold on. So we pediatricians really know about growth and the limits of normal puberty definition. Now, how to take a blood pressure is extremely important for all of you in any specialty which you are, and it's a commonly made mistake actually in by everybody. So I'm going to spend a few minutes on this. We must use a cuff of the appropriate size for the child. If we use too small a cuff, we will get a hypertension. If we use too large a cuff, we will get a normal reading, whereas the child actually had hypertension. So let us examine this. The width of the bladder cuff, the rubber part of the bladder, this is the width. Can you see my cursor? This is the width of the bladder. It should occupy 40% of the mid-arm circumference. So we place this bladder against the arm and see whether this dimension occupies more than 40% of the mid-arm circumference. Then only it is of an appropriate size, otherwise it's too small. This dimension is the most important dimension. The second dimension is the length. That is this one, the length of the rubber part of the bladder. And that is the one which we wrap around the arm, and it should cover at least 80% of the arm circumference. So if we make sure of these two things, then only we can interpret the blood pressure. Most of the time I find that as soon as there is a child, people use the pediatric cuff. For mid-childhood, older children, we don't need the smaller cuff. We will get hypertension unnecessarily, wrongly. If we don't are not able to fit a size on the arm correctly, we can very well use the thigh. We can put a cuff which is not sitting quite correct on the arm. We can put it on the thigh and listen to the popliteal artery sounds. Now, how to interpret the blood pressure which we get? Unlike in adults, where we have one figure, 120 by 80 or 130 by 90, in childhood, we have to look at the blood pressures as per centiles according to the gender, age, and height. Now, in 2017, the American Academy of Pediatrics and the American Heart Association have revised the interpretation of blood pressures. So we come to this. This chart, of course, is from the older American Academy of Pediatrics publication, but I've slightly modified to teach you the new modification, new definition. So you can see that this is a table for boys. Like this, there will be a different table for girls. Then you can see on the left-hand side, age. So the blood pressure for viewing hypertension, hypotension, etc. is different for a 1-year-old, 2-year-old, 3-year-old, etc. Then we can note that the blood pressure is 84, whereas a tall child of the same age, boy, his 50th centile is 109. 109. Now, 109 is actually more than the 95th centile for the short child. So height, so gender, age, and height is very important. So since we cannot mug up all of these numbers, we must have these charts as a ready reference. And this comes from American Academy of Pediatrics 2017, and it is up on the intranet, in the SGPGI intranet. Now, how do we then, once we have the chart and we have seen the age and the gender and the centile, how do we then interpret? This is given below. Normal BP is less than 90th percentile. That is equivalent in adults as less than the 120 and less than 80 diastolic, which we are familiar with. Elevated BP is 90th centile to 95th centile, similar as 120 to 130 or 129. Then stage 1 hypertension is more than 95th centile, but up to 95th centile plus 12 millimeters mercury, which is similar as 80 to 90 diastolic. Stage 2 hypertension is beyond the 12 millimeters after the 95th centile, and that is in adult equivalent to, or older child than 13 years, equivalent to more than equal to or more than the 140 and equal to or more than the 90. So this is how we view hypertension. All of you in various departments must be dealing with hypertension or hypotension sometimes. So this is extremely important. So I told you two extremely important things till now. One, how to measure the blood pressure, and secondly, how to view or interpret the blood pressure. Now for hypotension, these charts are not useful because we need the 5th centile. So a rough and ready calculation for below 5th centile, which would go with hypotension, is 50 plus age into 2. Okay, if it is less than, so if the age is 10 years, 10 into 2 is 20, 50 plus 20 is 70. So below 70 would be hypotension for a 10-year-old child. Coming now to investigations, a few investigations which are extremely common and extremely important. They are different in children. Creatinine. So many times I have reminded myself and colleagues, oh, it's zero point 0.7. No, 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 your baby is only 4 months old. Zero point 0.7 is not normal. So remember, uh, creatinine changes. It is relatively high in a preterm as compared to a term baby, and then it is lower than adults and older childhood, and then reaches only by late adolescence. It reaches into the adult levels. Similarly, potassium, calcium, phosphorus, they are all much higher. They are all much higher in a newborn as compared to the older child and adult. Phosphorus, very much so. You can see that the newborn lower end of phosphorus is 4.8. That is close to the upper end of normal phosphorus for an adult, which is 4.5. Thyroid hormone also, it is particularly of importance to us in endocrinology. Infants have higher T4 level than older adults. ECG, very different in babies as compared to older children and adults, but I won't go into the details. Coming to a few treatment issues. Drug doses. There are two drug dose resources on the SGPGI intranet. One is alphabetical by a very famous person from Australia. One is not alphabetical, but it gives lots of the adverse effects. So we have retained both the drug dose resources in the intranet. The IV fluid requirement and the blood volume are different in babies, and this is the calculation which pediatricians use. 100 ml per kg is the maintenance IV fluid up to 10 kg. I'm getting some disturbance. Uh, After 10 kgs and up to 20 kgs is 1 liter and 50 plus 50 ml per kg. And beyond 1500 is 1500 plus 20 ml per kg when beyond 20 kgs. The type of fluid, in the first 2 days, only dextrose. After that, N by 5 saline only for the first 3 months. Beyond that is N by 2 and normal saline. Blood, 10 ml per kg whole blood, 5 ml per kg packed cell. Susceptibility to infections. The different type of organisms which may affect a small neonate are different from those in infancy or up to 3 years of age, and then different in older children and adults. So we have different connotations, different implications for antimicrobial choice. The connotations of sepsis in a neonate includes that we must do a lumbar puncture and a urine culture automatically whenever we suspect sepsis. Some medications. Infants are G6PD deficient, so sulfonamides are not used in infancy. Valproate is contraindicated below 2 years of age due to the higher risk of fulminant hepatitis. Doxycycline colors the teeth, and we don't use it in small growing children. Anti-motility drugs like loperamide are a big no-no. Coming to ethical issues, we can use EMLA cream or xylocaine jelly applied before, where we are going to apply a Vigo or take a blood sample or do a bone marrow. Of course, infiltration with xylocaine. But even for IV sample and IV placement, we can use EMLA cream. Consent is a big issue. Those of you, when you do research projects and write your ethics committee submission, you will see that children are a vulnerable group. The resource people in SGPGI to quickly ask something in case you don't have pediatric people in your own department. In pediatric gastroenterology, neonatology, and pediatric surgery, everyone working there are dealing with pediatrics. They are trained in pediatrics. In critical care, the faculty is Dr. Banani Podar. And in genetics and in pediatric endocrinology, there are many people who are of pediatric background. In the general hospital, the pediatrician in the general hospital is Dr. Pyali Bhattacharya. In the intranet, there are two easily, as I already mentioned, two easily searchable dose databases. There are also separate tables for quick reference for antihypertensive, sedation, anticonvulsant, and of course the blood pressure centiles. So please make use of these. Sometimes by some technical glitch, one of these vanishes. If so, please talk to me. I'll get it put back. Thank you for your attention.